Namaste. Welcome to our series of talks where we will discuss the results of the Samrakshan program of the Indian Radiological and Imaging Association. Let's start with an important question today. Why are deaths from increased blood pressure still a major problem or a major concern during pregnancy in India? Why is that still a problem in India? Is there something we need to do about it? Is there something we can do about it? Can we reduce the risk for developing hypertension in pregnancy and consequently reduce the risk for deaths of the mother and baby during pregnancy? The Samrakshan program of IRIA, the Indian Radiological and Imaging Association, was conceived and founded by Dr. Rijo Mathew under the patronage of Dr. Hemant Patel and is an ongoing program in India since 2019. My name is Praveen Nirmalan, and I would like to share with you the evidence that we found in the Samrakshan program of the Indian Radiological and Imaging Association. We know that there are significant changes in the body of the mother during pregnancy. These lead to changes in several physiological functions, including changes in the blood pressure. An abnormal increase in the blood pressure beyond what is expected as part of the normal physiological response that occurs after 20 weeks of pregnancy is called as pregnancy-induced hypertension. Now, this can be an isolated increase of the blood pressure, where you only have an increased blood pressure, or it can be associated with effects on other organs of the mother, the neurological system, the renal system, the cardiac system. It can also be associated with reduced growth of the baby. Hypertension during pregnancy is a major cause of avoidable or preventable death of the mother and baby. If the mother and the baby survive, they may still suffer from short and long-term consequences, consequences that might occur much later after pregnancy, 5 years after pregnancy in the mother, as a young adult in the baby. So consequences that can occur much later after childbirth. So what does that mean for India? Let's look at the situation in India. Nearly 10% of pregnant women in India develop pregnancy-induced hypertension. 10%. That is, 1 out of every 10 pregnant women in India may have pregnancy-induced hypertension, increasing the risk of death for her and for her baby during pregnancy. Every year, nearly 24 lakh or 2.4 million pregnant women in India develop pregnancy-induced hypertension. So we have a large number of pregnant women in India that develop pregnancy-induced hypertension every year. Now, we must realize that the medical management of hypertension is an ongoing process. It's something that's happening already in India as part of the therapeutic management of a pregnant woman. But it's something that starts after the onset of hypertension. We have seen that a large number of women may need medical management during pregnancy in India. 24 lakhs or 2.4 million, that's a large number. And providing appropriate medical management for the appropriate duration may not be pragmatically feasible for such a large number of women. And even if we can provide, such a large number of women may not afford or be able to access the required care. So the question is, can we act earlier? Can we identify those who are at higher risk for the development of hypertension earlier during the course of pregnancy? And by identifying them earlier, can we prevent the onset of hypertension during pregnancy? Will that reduce the number of women who need intense medical management, improve survival, and reduce the complications and deaths for the mother and baby during pregnancy? And that was how we gave birth to Samrakshan in 2019 as a program that aimed to reduce preventable deaths of the mother and the baby during pregnancy in India through a compassionate, just, and equitable system that optimized existing resources and personnel. So the aim was to integrate with the existing antenatal care system and to optimize whatever resources we already had and using the trained workforce, healthcare workforce that we already had in India, not to recreate things again, but to optimize and integrate within the existing systems. So let's look at what was done. We initiated a screening of all pregnant women as part of the Samrakshan program between 11 to 14 weeks of pregnancy, that is, in the first trimester of pregnancy. We integrated Doppler studies with the routine ultrasound assessment that's done at that particular time period in the first trimester. We measured the mean arterial blood pressure of all pregnant women as part of this protocol. That is, we used a digital calibrated blood pressure machine to simultaneously measure the blood pressure in both upper arms of the pregnant woman. And this was done between 11 to 14 weeks of pregnancy. We collected the clinical history of each woman, we collected the demographic history of each woman, and we used all of this information to estimate a risk for the development of preeclampsia or hypertension during pregnancy for each woman. So we used all of this information, we fed it into a calculator, an online algorithm, and estimated an individualized risk for each woman. Based on the risk estimate, the value, we categorized or classified women as high risk or low risk for the development of preeclampsia or hypertension during pregnancy. Now, if the woman was identified at high risk, we discussed the findings with the managing obstetrician and recommended low dose aspirin 150 milligrams once daily at bedtime up to 36 weeks of pregnancy or the development of preterm preeclampsia or childbirth, whichever occurred earlier. So based on the risk stratification, which we shared with the obstetrician, we recommended to the obstetrician that this woman is at a higher risk for the development of preterm preeclampsia, and it might be better for us to start her on low dose aspirin if there are no other medical contraindications for the same. So the process involved the estimation of risk and discussing that finding along with the Doppler findings with the managing referring physician. So what did we find? We had screened 4,372 women. And let's see what we found. We found that the likelihood for a woman identified at high risk to develop preterm preeclampsia or hypertension in pregnancy was 6.64 times higher compared to a woman identified at low risk. So 6.64 times higher. We found that preterm PE developed in only 1.90% of the women identified at low risk. So when the screening protocol was identifying a woman, a pregnant woman, as a woman at lower risk for the development of preterm preeclampsia. It was almost always a correct classification. We also found that preterm preeclampsia did not develop in 75.6%, that's nearly 3/4 of the higher risk women or pregnant women identified at high risk for the development of preterm preeclampsia and who were started on low dose aspirin. So in a sense, you can say that the start or the initiation of low dose aspirin prevented or reduced the risk of the development of preterm PE in 75.6% of the high risk women. What did that translate to? We found that the magnitude of preterm preeclampsia reduced from 9.85% of the pregnant women to 2.76%. It's a big drop in the magnitude of pregnant women that have developed preterm preeclampsia. Now let's look at that with the context of what it meant or what it might cost or what it means to have these additional measures that we have integrated with the routine antenatal care screening. The cost of low-dose aspirin, if you are giving it from 11 to 36 weeks for a high-risk pregnant woman, is only 175 Indian rupees per woman for that entire duration. If you want to measure the mean arterial blood pressure properly, and we need 2 digital blood pressure machines so that we can do the measures simultaneously in both upper arms. The additional cost for a physician would be about 4,000 rupees for both the machines. Maybe a little higher, give or take a little, this way, that way. But approximately around 4,000 Indian rupees. That's the additional investment that the fetal radiologist must do or must make. The Doppler studies, when you are integrating that with the routine antenatal ultrasound studies, it's just an additional 2 minutes to 5 minutes per woman, per pregnant woman. So we can see that there's not too much that we have to add in terms of time, in terms of infrastructure or resources, in terms of cost. But we are getting a very significant improvement, a very significant reduction in the magnitude of preterm preeclampsia and consequent effects. So what's the take-home message from the Samrakshan program? We have seen as evidence from our population, evidence from a population of Asian Indian pregnant women residing in India and availing and accessing healthcare facilities available in India. We have seen that the screening and risk estimation for preterm preeclampsia, the classification, works. A significant proportion of those who are called as low risk did not develop preterm preeclampsia. When we gave low dose aspirin, we were able to reduce or minimize the risk for the development of preterm preeclampsia even in the high risk pregnant women categories. 75.6% of the high risk women did not develop preterm preeclampsia. That means we have a working solution. We have a screening protocol that works. We can and must estimate a risk for the development of preterm preeclampsia for each woman. And we must estimate that risk in the first trimester between 11 to 14 weeks of pregnancy. Once we classify the woman as at high risk, in consultation with the obstetrician and the managing physicians, we must recommend and work to start the woman on low dose aspirin 150 milligram once daily at bedtime unless there is a medical contraindication. And if you are a pregnant woman listening to this, What you must take home is that you must ask your doctor, you must ask your fetal radiologist, you must ask your consulting obstetrician or child care doctor about your risk for the development of preterm preeclampsia. That's something that you must ask when you're going for your first trimester assessment. Thank you for listening to us on the evidence relating to preeclampsia, the screening for determining the risk for the development of preterm preeclampsia in a population of Asian Indian pregnant women. We encourage you to start integrating the estimation of a risk for each pregnant woman between 11 to 14 weeks in your routine fetal radiology practice. Now stay tuned. If you have not yet subscribed to the channel, kindly subscribe to our channel and stay tuned as we will be bringing out more videos that provide information on various bits of evidence that we have derived from the Samrakshan program, evidence from our population. So stay tuned for more. Until then, goodbye, stay safe, be happy.